Welcome to the lecture on the medical conditions of the newborn. As part of our Step 2 high-yield review of pediatrics, we're going to cover 3 transient conditions: polycythemia, tachypnea, and transient hyperbilirubinemia, follow up with delivery-associated injuries and what we do about them, and finish off with common newborn infections. The big transient 3 conditions we're going to be discussing are transient polycythemia, transient tachypnea, and transient hyperbilirubinemia. And as we go through this, be keen to sort of clue into the features on why we're discussing all these at the same time. What is it that links them together, as well as what makes them different, and what are the other conditions surrounding them that we're differentiating them from. That's the key to getting the concepts right in an approach to Step 2. Let's start with transient polycythemia. There are a few concepts wrapped up in this diagnosis, and we're going to link them all together for a better understanding of what polycythemia is, and particularly then focusing on transient polycythemia. So polycythemia is when there's an increased concentration of red blood cells. This can happen in different ways. One way, you're going to have a decrease in plasma volume, which will indirectly increase the concentration of red blood cells. So if you think of the plasma, the red blood cells, the serum, if it's all in the vascular space, if you pull all the water out, the same number of red blood cells are going to be in there, but now there's less fluid, so you have an increased concentration. That's one way. That's an indirect polycythemia. Or you can have a direct polycythemia, in which you have an increased production of red blood cells, and that's largely what we're going to be talking about. Same amount of fluid, but you just pump in more red blood cells from somewhere. Recall that erythropoietin released from the kidneys is critical in signaling for the production of red blood cells, and a measure of EPO is a key feature in how we differentiate between primary and secondary polycythemia. So, focusing on primary and secondary polycythemia is when you have normal to low EPO levels. Primary means that the red blood cells are being directly produced primarily by the bone marrow with no other signaling. There's nothing signaling the bone marrow to release more and make more red blood cells. The primary problem is the production of red blood cells in and of themselves. This feedback inhibits the release of erythropoietin from the kidney. Different from secondary polycythemia, in which the bone marrow is operating fine, but there's a signal to release more EPO from other process or some secondary process that's causing the signaling of the release of erythropoietin from the kidney, which then moves to the bone marrow and signals for the production of red blood cells. Transient polycythemia is an example of secondary polycythemia. Now, focusing on why polycythemia is even important in the newborn, we have to focus that there are both pathologic and non-pathologic types of polycythemia. Now, polycythemia is important in and of itself because it can be harmful. It can lead to symptoms of related to hyperviscosity, decreased perfusion, and thromboses. If the hematocrit goes above 65%, the disproportionately high amount of red blood cells to plasma in the blood actually makes it too difficult for the blood to flow through small capillaries, and this disruption can cause a backup and even fatal clots in the venous system. Those newborns that are at the increased risk of developing a pathologic form of polycythemia are those who are large for gestational age, small for gestational age, and infants of diabetic mothers. These 3 groups are the most likely to have a polycythemia, which is related to a harmful condition and to be harmful in and of itself. Focusing now on transient polycythemia newborn, it's important to know that this is a benign condition. While we did say that polycythemia, if it gets bad enough, is in itself bad, there's nothing causing transient polycythemia that is a severe medical condition. It's most often related to delayed cord clamping, which is not that big of a deal, and it happened a lot. The delayed cord clamping causes a transient hypoxia throughout the whole blood system. So the transient hypoxia then triggers the kidneys to release erythropoietin. As we said, elevated EPO are signs of secondary polycythemia, but as the baby starts to breathe, oxygen tension in the blood increases, EPO production will decrease, and the hematocrit will normalize. Remember what the normal vital signs are for a newborn and how they're dramatically different from those of an adult, because tachypnea, which is fast breathing in the newborn, isn't really a concern until the baby is breathing greater than 60 breaths per minute. So you have to know that the normal range for a newborn is 40 to 60 to know that tachypnea is going to be something greater than 60. Because on step 2, they're very into giving you vital signs as a way of triggering you in to what the features of the diagnosis you need to be paying attention to. Now, transient tachypnea of the newborn, often abbreviated as TTN, is also called respiratory distress syndrome 2. Now, this is a benign condition, just like transient polycythemia. Transient tachypnea is benign, and it's most common in term and post-term infants. Now, while this is benign, it's important to recognize, and we're discussing it because you need to be able to recognize this to rule it out and differentiate it from more harmful diagnoses. Now, the cause of TTN is largely unknown, but there are 3 largely accepted theories that contribute to it. The first is excess remaining lung fluid. Now, this is supported by the finding that TTN is more common in those children that are delivered by C-section. Because they don't go through the vaginal canal that squeezes them as they are delivered, that normal spontaneous vaginal delivery squeezes out lung fluid. But if they're in the C-section, there's no squeezing. An excess amount of lung fluid stays in the lungs, and that decreases lung compliance and makes it harder for them to breathe. The second theory is related to pulmonary immaturity. Now remember that in preterm infants, they often look at the lecithin-sphingomyelin ratio to determine lung maturity. But in infants born with TTN, it's been noted that there's a deficiency of phosphatidylglycerol, even though there's a normal lecithin-sphingomyelin ratio. But the deficiency and insufficiency of phosphatidylglycerol is also a marker of lung immaturity, and that has been seen in TTN. And the third is related to surfactant deficiency or insufficiency. But regardless of the true combination of underlying causes, the general problem is with lung compliance, and this leads to increased work of breathing of the newborn. It's not just that they're not just breathing fast because they feel like it. So the management of TTN is not about what you do to correct the TTN, but it's what you do because you're worried about what might be there in case it's not TTN. So you give oxygen and you start antibiotics. If a brand new baby is breathing rapidly and you don't know why it is, you can't just hang your head on TTN because there are serious diagnoses that could also be there. So you put them on oxygen to decrease work of breathing, and you cover yourself for an underlying sepsis that you haven't diagnosed by putting them on antibiotics. You then immediately start a workup with a complete blood count, probably with a differential, and need to get a chest x-ray to see if there are signs of hyaline membrane disease or other signs of a pulmonary issue that you can't get on your physical exam alone. But the key to management is how are you covering yourself for the more dangerous things that you can't diagnose immediately, because transient tachypnea can look like more pathologic diagnoses. The takeaway points with TTN are pretty simple. This is a benign condition, and it's seen in post-term infants or term infants. Look for vignettes that involve uncomplicated C-sections and stable newborns with no other symptoms than just the tachypnea in and of itself. The goal is to give antibiotics, give oxygen, and watch closely, because what you're trying to watch out for is sepsis. You're worried about sepsis, even if you think it's TTN. You got to make sure the sepsis isn't there, but you got to cover yourself. Get cultures. If the cultures are negative, then you stop the antibiotics. But the management questions are, what are you going to do first? It's get them on O2, get them on antibiotics, watch. To understand transient hyperbilirubinemia, we have to know what hyperbilirubinemia implies and why we even care about it. So recall that bilirubin is a waste product from the breakdown of hemoglobin in red blood cells. When the production of bilirubin exceeds the elimination, the total serum bilirubin increases. This can happen in many ways. You can have an increased production with an increased amount of red blood cell breakdown and anemias, or you can have a decreased elimination, and even that has many different ways in which it happens. So a decreased uptake from the liver, decreased elimination via the biliary tract, increased reabsorption and enterohepatic circulation, all can lead to increases in total serum bilirubin. Now, recall that there are also two main types of bilirubin. There's indirect, which is the same as unconjugated bilirubin, and it's the more proximal product right after red blood cell breakdown. Unconjugated bilirubin is then taken up by the liver, and it's conjugated into direct bilirubin. Now, the way we calculate these in the serum is you take total bili, subtract the direct bili, because we can measure those directly, and then you calculate the indirect bilirubin. Now, there are many different conditions, both pathologic and physiologic, and that relate to hyperbilirubinemia. And it's always important to note the type of hyperbilirubinemia and its context, because that gives you a diagnosis and will help you pick out a form of management. Now, transient hyperbilirubinemia is a benign condition, but it's extremely common. It happens in 2/3 of newborns. And it tends to peak at days 2 of 3. So it happens in a lot of newborns. It's very benign. And around day 2 or 3, the bilirubin will peak, but not usually to toxic levels. And in preterm infants, sometimes the prevalence is a little bit higher, and the condition will last a little bit longer. So if you do have a preterm infant that was born maybe at 30, 28 weeks, then expect the bilirubin to naturally peak at day 4 or 5, and you can almost guarantee this is going to happen, as it happens in 80% or more of preterm infants. Transient hyperbilirubinemia tends to be a unconjugated, indirect hyperbilirubinemia. It's primarily due to an increase in the breakdown of red blood cells that are containing the hemoglobin F, the fetal hemoglobin, that's no longer going to need to be used as the infant starts circulating and eliminating it from its system, switching to a normal hemoglobin. This is potentiated in the newborn because they have a new liver. They haven't had to detoxify their blood, which is primarily done via the mom. But now that there's no more an umbilical cord, the liver's got to detoxify everything, and so this liver isn't used to it. Think of it as like a brand new liver, so it doesn't uptake the unconjugated bilirubin as well as it will in the future. So you have increased production and you have decreased elimination, which leads to an increase in total serum bilirubin. Now, to finish our discussion on transient hyperbilirubinemia, there's a couple tips I want you to commit to memory. They're going to help you discern sort of transient hyperbilirubinemia from the more pathologic concerning hyperbilirubinemia that are from a different cause. So any hyperbilirubinemia, whether it's conjugated or unconjugated, if it happens on the first day of life, it immediately needs to be evaluated. And the next is any conjugated hyperbilirubinemia, regardless of timing, whether it's in the first day, the first week, or the second week, or any other time. Anytime it's a conjugated hyperbilirubinemia, it also immediately needs to be evaluated. And something to keep in mind in case they give you lab values on the test and you have to figure out whether it's a hyperbilirubinemia by yourself based on the lab values, you need to be looking for bilirubins that are greater than 2 milligrams per deciliter. That quantifies and qualifies for a hyperbilirubinemia. So that covers our review of the 3 transient conditions: polycythemia, tachypnea, and hyperbilirubinemia. Remember that they're all benign conditions, but the point of covering them is how we differentiate them from more pathologic things, because differentiating and ruling out and covering more pathologic diagnoses is the key to management. What follows is a list of injuries that are commonly occurring in newborns during delivery. They don't tend to be particularly high yield when it comes to the test, and some of them are even fairly intuitive, so I'm just going to mention a few important facts about them here. Subconjunctival hemorrhages are benign microhemorrhages in the eyes of newborns. They happen because as the child moves through the vaginal canal, there's a lot of pressure that's generated. Remember that we said that pressure is actually enough to remove fluid from the lungs that decreases the incidence of transient tachypnea of the newborn in those that are vaginally delivered. That same squeezing pressure, when it happens in the head, causes little microhemorrhages to the eyes. This is benign, and it's not different from the little microhemorrhages in the eyes of children and adults after several bouts of vomiting. Scalp injuries are also very common in newborns, and the main 2 that you need to know are the caput and the cephalohematoma. Know that if you even see these, what you really need to know is that the caput does, as in it does, cross suture lines of the skull, and that's because the swelling in the hematoma is actually in the scalp itself. So you can have a hematoma that goes all the way from the front of the scalp to the back of the scalp, crossing suture lines, temporal, frontal, etc. The cephalohematoma is swelling of tissues that involve the bone, so that will not cross suture lines and will be localized to a specific suture area. Facial nerve palsies can occur with forceps delivery. And here's a picture of the forceps. The forceps wrap around the infant's skull and apply traction. Recall that the facial nerve runs behind the ear before entering the parotid gland. So if you wrap big metal objects around the face, you could easily damage a fairly superficial cranial nerve as the facial nerve. This will still resolve on its own, and it's a benign process. The two conditions I want to go into greater detail are brachial palsies and clavicular fractures. Brachial palsies are important because they're relatively common now, and they're probably going to become more common as birth weights are on the rise. And that's because these injuries are usually occurring in large or macrosomic infants. These infants are predisposed to shoulder dystocia, which is when the anterior top shoulder of the baby being delivered gets stuck behind the mother's pubis during delivery. As you pull on the head and the shoulder stuck behind the pubis, there's traction along the area of the neck against the shoulder that can cause compression or damage to nerves running through the brachial plexus. One example of a brachial plexus injury that can happen in a newborn is Duchenne-Erb paralysis. It is the most common brachial plexus injury in newborns. Not necessarily the most common brachial plexus injury out there, but in newborns, as a condition associated with delivery, Duchenne-Erb paralysis makes up 90% of the palsies. It's commonly called waiter's tip paralysis because of the condition it causes, and it affects the part of the brachial plexus that is most proximal, the C5, C6 region. And as we said, it's called waiter's tip paralysis. And that's because when this occurs, it leads to the inability to abduct, abduct the arm or externally rotate it. This leaves other muscle groups, the antagonistic muscle groups, unchallenged. And so the default resting position of the arm will be internally rotated and adducted. So it's going to be turned inwards, and it's going to be stuck against the side of the arm. And apparently that's how waiters used to ask for tips, because that's what got its name, waiter's tip paralysis. The next most common one, is Klumpke paralysis. This involves the more distal region of the brachial plexus, C7 to T1, and it's called claw hand. It also is commonly associated with Horner's syndrome because of the area that's affected. Recall that Horner's syndrome, write this one down because it shows up in your neuro section as well, is when there is a loss of sympathetic innervation, sympathetic to one side. So unilateral loss of sympathetic innervation that leads to small pupil, miosis, droopy eyelids, called ptosis, and a lack of tears, anhidrosis. The syndrome is present whenever the sympathetic chain is compromised, and this is also seen, going to your pulmonary and oncology sections, when there is a tumor of the upper lung, like a Pancoast tumor, or carotid dissections. So think of Horner syndrome and Pancoast tumors of the lung, carotid dissections, and Klumpke paralysis with brachial palsies. This diagram isn't just a chance to review the palsies that are most common in newborns, but you can use it as a chance to review and recover your knowledge of the brachial plexus as a whole. It does come up in other sections. So recall there's a way to remember the brachial plexus as it is set up is roots, trunks, divisions, cords, and branches. A mnemonic I've used in the past is Randy Travis drinks cold beer. But maybe that only works for you if you know and like country music. Regardless, in Duchenne-Erb palsy, which is the most common brachial palsy in newborns, causing over 90%, is loss of the more proximal aspect of the brachial plexus. We lose C5 and C6. And this is the only contributor to the superior trunk. And so you lose a major part of the superior trunk, which is the largest contributor to the lateral division and partial contributor to the posterior division and the posterior cord. Loss of this means that we lose axillary nerve innervation to the shoulder, and this leads to the loss of abduction. This is why you can't abduct. You can't move your arm out. You can't lift it horizontally. It's also, we lose the innervation to the musculocutaneous nerve off of the lateral cord, and the musculocutaneous nerve innervates the supinator of the arm. If you can't supinate, then you pronate the arm and you internally rotate it. Hence, you get the lack of abduction, the lack of supination or external rotation, leaving the arm internally rotated. and adducted next to the body, hence the waiter's tip position. In Klumpke paralysis, the more distal regions of the brachial plexus are affected, with the loss of C7 through T1. The middle and the inferior trunks are affected, and because the medial cord and its more distal branches are entirely made up of contributions of C to T1, that's where the ulnar nerve is coming from. The ulnar nerve is severely affected. Recall that the ulnar nerve innervates the extensor muscles of the hand. So if you knock out innervation of these extensor muscles, you can't extend your fingers, then, like what happens in Duchenne herb paralysis, the unchallenged antagonistic muscles take over during resting state. This is why at rest, during Klumpke paralysis, your hand is in a claw form. They flex because they cannot extend, which is why it's called a claw-like paralysis. Now, I only want to mention clavicular fracture because it's the most common fracture in newborns, and therefore it is the most likely fracture of the newborn to show up on your test. Like the palsies, clavicular fractures are usually the consequence of shoulder dystocia. Thus, I recommend you understand the concept of shoulder dystocia, where the anterior shoulder is getting stuck behind the mother's pubis, leading to increased traction on the head. You need to review this in your OBGYN material because it's a relatively common issue in pregnancy and delivery and leads to many untoward consequences of the child. The basics you need to know are the tools and the management. The best way to the best diagnostic tool for clavicular fracture in a newborn is going to be the x-ray. It's going to be easily seen. You're not going to need a CT. It's not an MRI. Don't do an ultrasound. It's a bony issue. You need to get an x-ray. The most appropriate management, as surprising as this may be, is not surgery, but just immobilization. This is the most common fracture. They most commonly heal on their own. You do have to sling it, or you have to cast the baby's entire arm to make sure they don't move it, but you don't need to do surgery. Only if it doesn't improve after a long, long time is surgical intervention warranted. I'm highlighting shoulder dystocia because of its important relationship to not just clavicular fractures, but palsies and other complications of pregnancy. Now, as we move on to discussion of sort of congenital infections and newborn infections, you have to review normal vital signs of a neonate for any discussion of sepsis or newborn infections, because step 2 question stems can depend on your knowledge of what, quote, sick looks like in a neonate and what it sounds like, because if they sound septic, you have to think they're hypotensive, they're tachypnic, they're tachycardic, but those terms, they're not going to say, they might not say tachycardia, tachypnea, and hypotensive. They might just give you the vital signs, in which case you got to know that the heart rate from a newborn is regularly above 120. And we don't really say tachycardia until it's above 160. Respiration rate is 40 to 60. And so knowing tachypnea in the condition of sepsis is similar to being able to recognize tachypnea for transient tachypnea of the newborn. Neonatal sepsis is largely divided into 2 broad categories, early versus late. This categorization is based on when it occurs and the organisms most likely to cause them and where those organisms came from. Now, early sepsis is largely defined as sepsis that occurs in the neonate within the first week, in the first 7 days. Usually, this is in the first 72 hours. So we're talking septic kid presenting at day 2, day 3 is the most likely thing you're going to see in a vignette when you're thinking early neonatal sepsis. The infection is presumed to get in the newborn during delivery. It's a perinatal infection. Got it from mom. Late sepsis occurs after the first week. It's thought that the organism causing the infection is picked up in the environment, and the bacteria are different in that situation, and how they got the bacteria is different in that situation from early sepsis. But how you manage and what antibiotics you give are going to be the same. So here we go. Early sepsis, GBS, E. coli, Listeria. Those are infections picked up from the mother during delivery. Or Staphylococci, E. coli, and GBS. These infections are thought to be transferred sometime from the environment, could be from the mother, but mother counts as the environment, after 7 days. Now see how E. coli is on both of these. Remember that the mother is colonized with E. coli in the perianal area, because E. coli is the most common cause of urinary tract infections in women, so it's not a stretch to think that the old coli can be transferred from the anal region to the vaginal area where the child's being born. But E. coli is also fecal orally transferred in the environment, because the kids are crawling around, a lot lot of things end up in their mouth, so it's easy for E. coli to also be transferred as an environmental pathogen, but in neither case is it the most common. Coag negative staph and late sepsis, GBS early sepsis. But the management is going to be the same because any septic that comes in is going to get IV fluids, cultures, and empiric antibiotics. The first step in management in a kid with presumed sepsis is you get a line in them and you start giving them fluids. Because sepsis, hypotension, that's death. That's the bad issue. We need to keep their organs perfused. It's the primary goal, early intervention in sepsis. And the antibiotics are also going to be the same because they're empiric. You're trying to treat for everything because you actually don't know what the organism is. This is a list of 3 on both sides, so you can make sure you have your bases covered. But AMP and GENT and cefotaxime are the most common antibiotics used in neonatal sepsis. Now, torch infections are a very popular topic to mention in step 1, but they're covered to a lesser degree in step 2. So we're going to put them all on one page so that we can distinguish between them on what the most defining diagnostic features are and what the treatment modalities are. So our first one is going to be toxoplasmosis, chorioretinitis, hydrocephalus, and ring-enhancing lesions. I want you to circle and highlight for yourself chorioretinitis and ring-enhancing lesions for toxo because those 2 features are seen in another torch infection. The best initial test for toxo is IgM antibody to the toxo, but it's not totally definitive because those antibiotics could be from the mother themselves. It doesn't mean the kid necessarily has a toxo infection. But the most accurate test would be identifying toxo in the blood of the child with the PCR. Treat with pyrimethamine, sulfadiazine. Syphilis used to be much more common than it is now, but its presentation in the neonate is not all that different from some of the presentations of an adult with syphilis. You get the rash in the palms and the soles. The things that you don't see in adults that you see in the kids is the Hutchinson 8th palsy and the saddle nose and the frontal bossing. That's congenital malformations related to the infection in utero. The best initial test is the same in this kid as it is in an adult. You do a VDRL, RPR. Those are indirect tests for syphilis. The most accurate test is dark field microscopy, but it's hard to do because there's usually no open wounds in the children. But that's great because you're actually visualizing the spirochete in a dark field microscopy. But you're most likely going to do for your most accurate test in syphilis is FTA-ABS. Treat with high doses of penicillin for weeks. Rubella is a harmless rash generalized viral infection of an adult. If I got rubella today, no one would bat an eye at it. But if a pregnant woman gets rubella, it causes devastating problems in her unborn child. It causes a patent ductus arteriosus, cataracts, so another eye finding, not the same as chorioretinitis and toxo, but it's an eye finding, causes deafness, and the deafness is a key feature, almost a pathognomonic feature on step 2 for a congenital rubella infection. You don't really see deafness in other torch infections. But diagnostically, you're going to do the same thing in rubella as you do in toxo. The elevated maternal rubella IgM, along with this clinical picture, is what's going to help you diagnose rubella. Because IgM in the mother doesn't guarantee that the child has the same infection, but with the clinical picture, it's the best scare that you got. Now, this viral infection, unfortunately, doesn't have any antivirals to give it, so it's supportive therapy. CMV is also a terrible infection for the unborn child. But here's the one that I want you to sort of juxtapose with toxoplasmosis because there's a lot of similar features that can get mixed with each other. And easily, when you're presented with many torch infections and tables to look at, you don't want to get them confused. So it also has chorioretinitis. CMV, chorioretinitis, toxoplasmosis, chorioretinitis. It also has periventricular calcifications. There's also lesions in the brain of toxoplasmosis. So you need to single these 2 out as toxo and CMV as the 2 major torch infections that have findings in the brain and findings on the retina. Major differences are there's the hearing loss in CMV, along with the fact that the brain findings are periventricular. There's no hearing issues in toxoplasmosis. And when you do an MRI of a child with toxo, the ring-enhancing lesions are all over the brain. They don't pick a particular spot. But CMV, it's periventricular. They'll be lining the ventricles, and that's classic a CMV congenital infection. Best initial test is going to be looking for viral titers, a very specific test. And then you do your most accurate and most specific test is your PCR and treat with gain-cyclovir. Gain-cyclovir being the same antiviral you give adults with CMV. And lastly, there's herpes. And herpes can have dramatically different presentations, so I think you're unlikely to be quizzed on the different presentations of herpes because they can be different based on which week the child's presenting in. It can be a full-blown disseminated skin infection. It can be an isolated nervous system infection. It can be both. So I would look for vignettes that really guide you towards a herpes infection. Perhaps they'll say like, oh, mother has a history of cold sores and has open, painful herpetic lesions on the vaginal area, giving you strong indications to believe that this is a congenital herpes infection. And then they might guide their question more towards what are the diagnostic tests. In this case, it's zinc smear, which is very sensitive but lacks specificity. And then there's the most accurate PCR. But even though the zinc smear is sensitive, it doesn't mean you can do it in every child. It might not even be the best initial test. You might go for a PCR. Treatment for herpes is going to be acyclovir. The same treatment for herpes you use in adults.